Good morning. You're now listening to Kingston Community Radio, airing on FM 92.5 and AM 920, WGHQ, Kingston, New York. This programming is brought to you by our listeners and corporate underwriters who are interested in presenting local community radio. The opinions expressed on this program do not represent those of Pamel Broadcasting or Kingston Community Radio. Listeners are encouraged to send in $10 per month to help bring this program to you, and mail your contributions to Kingston Community Radio, Post Office Box 4364, Kingston, New York 12402. For more information or to donate online, visit our website at mykcr.org. And good morning, and this is a very, very special morning, the morning of love, Valentine's Day, February 14th, easy date to remember, and 11 degrees starting out here in uptown Kingston, and we'll be right back after these messages.
Don't. Just don't. If you see a low-hanging or downed wire, don't touch it. Don't move it. Don't go near it. Don't drive over it. It may be a power line carrying an electric current strong enough to kill. But here's what to do. Stay at least 30 feet away and call 911. Central Hudson will take care of the problem. If you come close to a wire, shuffle away with small steps and watch your step. Wires may be hidden in fallen tree limbs or near water. Your safety matters.
Hey, Dad, your prescription will be ready in just a minute. Hey, Dad, your laundry will be ready in just a minute. Dad, your lunch will be ready in just a minute.
Hey, honey, why don't you take a minute?
When you help care for a loved one, you give them as much time as you can. But it's just as important to take time for yourself. AARP can help. Find free care guides to support you and your loved one at aarp.org/caregiving. That's aarp.org/caregiving. Brought to you by AARP and the Ad Council.
Hi, this is Diane Eastwick from Athens, New York, and I support Kingston Community Radio, and so should you.
And you're listening to KCR, Kingston Community Radio, AM 920 and 92.5 FM, and streaming online at mykcr.org. A little bit about the weather for the next 3 days. Today, even though it's quite cold, there is abundant sunshine today, so enjoy that. It's going to go up to about 23 today. And then mainly clear skies, goes back down to 9 degrees tonight. And Tuesday, sunny along with a few clouds. Sounds good. 32 degrees high. And Tuesday night, going down to 14 degrees. And then Wednesday, it pops up to 44 degrees with partly cloudy skies. And Wednesday night, cloudy skies, low of 38. And no real precipitation in sight. So we're going to have some good sunny days up ahead. And you're listening to KCR, Kingston Community Radio, AM 920 and 92.5 FM. 845-331-9255 is your phone number. It's not 845. 845-331-9255 is your call-in number. And, and Dr. Eric Stanberg's in the on-air studio, and let's say hi. Good morning, Dr. Stanberg.
All right, good morning. Welcome to this morning's show, February 14th, 2022. Awfully wintry out there today, but it is nice to make the drive in with the sun up, which is a stark contrast to maybe 6 weeks ago, so that's always a good sign. Anyway, I'll be here until 9 a.m. Robin will be joining me, and we also do have a guest coming to the studio. Her name is Dr. Elizabeth Levine. She is a colleague of mine for over 20 years, maybe even inching up to 25 years, and she is the head hospital. She is the director of the Hospitalist program over at Northern Dutchess Hospital, and we're going to just have a general conversation about medical-related issues and hospital-related issues, and an interest. One area of interest for Dr. Levine is also what they call end-of-life care, getting people to kind of think about, oh, there is Dr. Levine right now. Come on in. Do you know Dan Gatus?
Hi, Dr. Levine. How are you? Good morning.
You sit right there. Good morning. I don't know. Maybe we can start by talking about the confusion over what is the mask on or off. But we'll be here till 9, and Dr. Levine's joining us. She's here right now.
Oh,
And as I was saying, she's been a colleague of mine for over 20 years. So I was a resident here in Kingston. This is where I trained, and Dr. Levine was actually one of my attending physicians. So she taught me everything she knows
for 1 month.
for 1 month. But that's all it took. Wait, that doesn't sound right. Anyway, you want to get a little bit closer to the mic.
Oh,
Yeah, let's move the mic.
okay.
There we go. It's like the bowl of soup. You know?
Perfect, yeah.
And the bowl of soup closer.
There you go. That's a perfect analogy.
And Robin will be joining us as well. So
Yes.
good morning. How are you?
Good. Cold.
Cold.
Yeah.
And you live uptown, right?
Yes.
All right, so we'll be here till 9 a.m. Dr. Levine is welcome to stay as long as she wants. Are you working today?
I am sort of,
Sort of
not
working.
clinical, but
Dr. Levine recently assumed the reign, so to speak, of the hospital medicine department over at Northern Dutchess. So that's what she's referring to, the never-ending task of the never-ending administrative duties.
administrative duties.
Yes, they never do end, right?
No.
All right, so good morning. How are you?
Good.
It's a little
Good.
like a coffee chat. Did you bring any coffee or anything?
I know. I didn't have time. It was
Oh.
early. I had to get up so early.
They do have it. Yeah, no, these are like the old days. Remember, we used to have to get up early at 7 a.m. and right, what time? We have a residency program over at Northern Dutchess Hospital too. They do sign outs at even earlier, I think.
Yeah, maybe 6:30 a.m.
Yikes,
Yeah,
that's early.
Yeah, but they need to get there and see the people before we get in. Really. That's-
Oh, the life of a resident.
Yes.
The what they would call pre-rounding.
Yep.
All right, so I like to kind of start with my guests, kind of like interviewing you a little bit, how you who you are, how you wound up here in Kingston. So who are you, Dr. Guzman? No. When did you come to Kingston?
Oh, it was like 96 or 97?
Yeah,
Was
yeah.
that when you were?
Yeah, I was in the midst of the residency.
Yeah.
By the way, I loved my residency. It really was a special time. I know that goes completely contrary to what people always say about residency, but it really, it just was a really nice time, for me, personally and professionally.
I felt that way about mine
Did you?
also.
Yeah.
Yeah. Especially looking back.
Looking back, we didn't know how good we had it.
Yeah.
Well, it is true, that the, it's kind of like being in high school, so to speak. Well, assuming we had a good experience in high school. It's kind of like
That's
being in high
right.
school.
It was a lot better than high school.
I gotcha. High school is a relative term.
Yeah.
High school was a neutral for me. It wasn't awesome. It wasn't negative. It was kind of in the middle. Anyway, so you came up to town, and was this kind of your first job out of
No.
residency?
I did my residency at St. Vincent's in the village in the city. And I worked for about a year and a half in a faculty practice,
Right.
teaching, that kind of thing down there.
What brought you up to Kingston?
My ex-husband and I wanted to live in the country. We wanted to be close enough to the city to be near my parents at the time, and came up to New Paltz one weekend
Right.
and thought people were like incredibly nice. We couldn't believe how people treated us, so we were like, we want to live here. And
What do you say about the city?
it's different. It was so friendly. We thought everybody was just high, actually. But it was, perfect with hiking and, just had a lot. And
You were attracted to the area for kind of quality of life. It's true now, even though this area is hot. It's still cheap to people. And the costs are skyrocketing. But when you're coming out of Manhattan and Westchester and North Jersey, it's still quite cheap.
A $350,000 house is quite cheap.
That's
if you
right.
look at Brooklyn, Brooklyn Heights, that kind of an area.
It does kind of squeeze people out, but that's a different. We'll save that for other mornings of
Yeah.
the radio show. That's on our.
And we do it in the other mornings.
That's all right. I won't go there. Anyway, so you came up in Kingston. I know you practiced. Did you join the institute right away, or were you with another practice?
I commuted for a short time, so maybe for half of a year I commuted to the city. I would stay down there a couple of nights a week, and eventually I got the job at the institute and worked there for a year and a half. Yeah.
Okay, gotcha. You know, there's one theme of the show, which is there's many themes of the show, but one theme is kind of this instability of medicine, this kind of people kind of coming and going, a real frustration with patients. You know, oh, I like Dr. So-and-so, but then he or she just disappeared.
Yeah.
And we really do disappear in the middle of the night. It's like we never, abducted by aliens, or we just spontaneously combust and we've no longer existed anymore. So that is something. But I think you and I have spent our career kind of trying to institute a stability amongst a industry that maybe is not so stable. Does that make sense?
Yeah, definitely. Yeah.
By the way, a little footnote on St. Vincent's. Okay, does the St. Vincent's, is it still there?
No, they're condos. They're actually condos. They, how many years ago? Maybe it was, it was a while ago. There were some people like Dr. Stefanchek and Palmero who had to change their fellowships. They had to leave there and go elsewhere.
So doctors, we always like to plug our colleagues too and let people know the medical resources that are here in their own community. But Dr. Stefanchik is a kidney specialist and nephrologist, and she really does some wonderful work. And Dr. Palmero is an endocrinologist, specialized in diabetes and thyroid disorders. He's kind of doing some telemed stuff right now, but he's a good guy and he does good work.
He's been on the show, he said last night, many times. Back in the Dr. Hanovites.
Right, the
days.
Hanovites.
Yeah.
I would be thrilled if Dr. Palmero decided to hang a shingle in Kingston again. But
I know we all would be.
Right.
He's doing other stuff he loves.
So what happened to St. Vincent's, though? I always found this was a huge story, such a harbinger of what was going wrong with our healthcare system. What happened?
I don't really know.
Well, not details, just in general, what happened?
Yeah, it closed. Hi, Robin. It closed, and it just, people went other places like Beth Israel or
Right.
NYU. They were just and it was a financial thing, I believe, why it closed.
St. Vincent's was a hospital with tremendous history, providing care to immigrants from the mid-1800s, I believe, onward. A real center point of the HIV crisis in the 80s, and then just could not sustain itself by, I don't know, it was about 2010 or so, and closed. And now it's condos, as you said. So to me, when I heard that story, I said, this is a big sign that something is wrong with our healthcare system.
Absolutely.
That this institution, cannot be preserved in some way.
Do the condos have extra oxygen? And you get two beds to a room?
They have call bells, too, for takeout.
All right. So we're talking about Dr. Levine and how she wound up here in Kingston.
Hi, Robin.
Yeah.
So tell us about how and when and if, you definitely did it, but how and when did you wind up over at Northern Dutchess?
Oh, that was a journey. I went to a few other places too, like you said. I disappeared, and yeah. So after the institute, I joined Kingston Internal Medicine with Dr. Roberts, Corsones, Durcola.
Which actually is the remnants of that practice eventually kind of morphed into which I'm part of right now.
Yeah, we're all related in some way.
That's right.
Definitely.
It's like a big family tree. We'll see all these branches and how we're all interconnected in some way.
So that was primary care, and then I joined Karina.
Okay.
Dr. Karina up in Shokan, and then Dr. Heller. And so for 12 years, I had a practice who followed me for the most part,
right,
which was cool. And it was, giving up my practice was one of the hardest things I ever did, but it was also what I needed to do because I needed to practice medicine in a different way. I, like patients, was frustrated with primary care. So I left.
When did you come over to Northern Dutchess?
8 years ago. Yeah, I'm not new anymore. I used to always use that card, like, I'm new here.
But there is the message, though, kind of like, you kind of, you're here now, and, things, you haven't gone anywhere, so we, you and I kind of looking for that stability in our professional careers. We're able to kind of find it and also in a way kind of create it and sustain it, I would say.
Mm-hmm.
Yeah, patients always talk about the old days where they had their doctor, the old primary care model, which is very hard to find nowadays. I know there's a few left here in Kingston, but for the most part, all primary care is with corporate type of backing. So, but what's the difference between a hospitalist and a primary care physician? What would you say is?
That's a very, well, go ahead. Tell
It's
us
a
what a
great question.
hospitalist is.
I call myself like the primary care physician in the hospital.
Yep, that's
So-
exactly what I think. Yep.
You know, I'm like I take care of, I kind of organize your care, just what primary care docs do in the office. I'm like I don't know, I want to say the gatekeeper, but I hate that word. So,
Yeah, that word didn't really turn out to be the best choice of terms. For
no,
us.
it was terrible.
Gatekeeper, because it's like as much as the gatekeeper's letting people in, the gatekeeper's keeping people out, and that was not a good image for a doctor.
Yeah, yeah. So,
Back to the drawing board with that. But anyway, you let me go off on that tangent right
no,
there.
I know, we could talk about that.
That's
for a
right,
while,
semantics.
too. Yeah. So, yeah, I kind of organize your care and I take care of you, basically, in the hospital. And admit you, take care of you while you're there, order consultants to see you, and then discharge you. So, yeah.
You know, the hospice program, and I've been privileged to be kind of what's the word? I sometimes call myself a substitute teacher.
No, you're part of it.
All right,
You're
thank you very
definitely
much.
part of it.
But really, it's a fabulous collection of doctors and nurse practitioners. We had Laura Coriat and Sherry Chazen on a couple months ago as well. You know, and in the
heard
past,
that.
we've also had Dr. Scaduto on. We had Dr. Arizny on. I'll have to nail down a few of the others in the near future. But really, everything that should be, that a hospice program should be, that kind of personal a connection. And by the way, without getting into the details, Northern Dutch, and I'm always a little skeptical about the hospital rankings and whatever. I always kind of say, you know, every hospital claims in some way to be number one, you know, and I always say if a hospital says they're number 6, you should go there because at least they're telling the truth. But the Northern Dutchess is a 5-star hospital. Right, it's a CMS ranking, and I can't remember the exact number, but it's one out of only about 100 hospitals in the country. Maybe more than that. You don't hold me in the actual number.
Yeah.
But it's a big country, so that's a lot of hospitals, and a rather small group for Northern Dutchess to be a member of.
I think it's within our size hospitals. Yeah, so that narrows it down a bit. But yeah, it's a great place. So I could tell you
Sell it short. Come on.
the way that I got there was I was working at Tenbrook. I left out Tenbrook, which
Tenbrook,
you worked
okay.
at Tenbrook too.
Yes, I did.
So I worked there for 16 years total between the Institute and onward. But I used to get the patients from Northern Dutchess, and I would read about the care that they got there, and I would see Dr. Scaduto, Harizny, Massoud, and the type of care that they got. And I was like, I'm interested in that place. And then I visited my kind of father-in-law, I'll call him, at Northern Dutchess, and I was amazed at the care that he got. And that's how it went. I talked to one person about it, and he hooked me up and interviewed with Dr. Sabia, and that was it. Yeah.
Right, you always refer to it as a small town hospital, but it's really a wonderful place. So just for the layman out there, like myself, which is like my role here on Medical Mondays, is that so when you go to the emergency room, it used to be your doctor that would come see you at the hospital, right, back in the day, but they changed that model. So instead of your doctor coming to see you, they have these doctors, the hospitalists. So they really are in charge of like your total care. It's kind of like your doctor in the hospital. So they'll call in any specialists that need to see you. They'll review all your medications. I mean, I was amazed. We recently have gone through a whole medical issue with Eric's mom. But this has been such an enlightening experience because, you know, to see everything is like in action, you know. So, like, they usually kind of, like, wipe the medicine slate clean and then see exactly what the patient needs from here on out, especially after some acute illness. So, being hospitalist is, that model came in because they really thought if you were full-time in the hospital, you could be a better doctor while patients were in the hospital, correct?
Yeah, that's a good discussion. So what do you think, why did it happen? Why do you think the hospice movement
Yeah.
it became a standard of our care.
Well, I think it was dictated by the way that we practice medicine and the pressure that primary care doctors have in the office, and there's no time really to come to the hospital to preserve your time so that you can fully be in your office. So that was a piece of it too. But then I think they realized that hospital medicine was itself a specialty, and there are trainings in it as well. So I think for all those reasons, it just became like the thing. And now at Northern Dutchess, no primary care doctors come in and see their patients anymore. We, like maybe 3 or 4 years ago, we had 2 people who still did it, and then that was it.
Right. So it was kind of, there were 2 ends of why, how and why it happened. One was that the business, and that's an awkward term when we say the business of medicine, but it got harder, and so the job of a primary care provider got harder, more pressure to maintain the bottom line and having to do more, and the idea of going to the hospital became kind of unsustainable for many people. And then at the same time, the world of medicine just inherently getting more complicated, both in the hospital and out of hospital. There's some obvious advantages, the pre-hospital era. And by the way, I left my private practice in 2011. We were at the time still rounding on our own patient. We would round in the morning, and kind of, in the evening, maybe we'd go back and admit someone, or there were times if something had changed, if someone was unstable, we'd go back again. But the idea that, for a very simple reason for the hospitals is if something changes in the course of a day, they're there. Communication is very difficult and challenging. Although the primary care hospitals partnership could kind of help out with that a little bit. And I find that something that's easy to do.
Absolutely, yeah.
So those are kind of the 2 ends of how and why it happened.
So there is a lot of handoff between primary care and the hospitalists.
Well, it's a great word that you use, handoff, because it's exactly what we call it.
That's right.
The handoff. And they even get more technical. They say the warm handoff versus the cold handoff.
What does the cold handoff
Oh,
look
that's
like?
they get cold shoulder, Well, the idea of a warm handoff, I guess, is some sort of direct communication between providers. There's also in my office, we have a care manager who communicates directly with, I guess in the hospital, they call them case managers. So the world of semantics. One letter makes a difference between a case manager and a care manager. So that also is important too. And that's a big focus of medicine now, and Medicare is paying attention to that too, because it is true that when the hospice movement kind of became established, Medicare started to look at it and say, okay, one of the impetuses was to control costs. I mean, the argument was that, maybe a hospital doctor could go back in the afternoon and say this patient's stable and discharge the patient, or the hospital patient, the doctor just being more experienced would be more, using resources more reasonably. But Medicare kind of stepped back and said, I don't know, it's not happening as much as we'd like. So they began to pay attention to what we call bounce backs or readmissions. And in many cases, unfortunately, these do occur because some information got kind of not communicated.
Yeah, definitely.
Yeah, so Medicare now is kind of, and when Medicare starts doing something, the insurance companies start kind of following suit.
I know,
as well.
it's really strange.
It is kind of weird, right? So anyway, there's a lot of focus now on communication and
quality of care too for patient satisfaction.
Yeah, well, that's a whole other.
When we communicate, they
Right,
seem to do better. Yeah,
absolutely, and there has been dramatic improvement over the past 5 years. From my perspective, with Northern
that's
Dutchess.
good to know.
Still got some work to do with some of our other hospitals, but I like to think they want to do better.
Yeah.
Right. Well, how many times are you just getting notification? Like, how many times do you not know that one of your patients was in the hospital?
It's an issue. I mean, Northern Dutchess, we share a computer system. I'm staring at the screen right now, and there is a system in place. Again, not but North Dutchess it's pretty much close to 100%. You know, there are other elements of the organization where sometimes it doesn't happen, and then with other community hospitals, the communication doesn't really. There's a lot of room for improvement there, and it's very important.
Is it because those computer systems don't talk to one another?
Part of it.
Yeah.
But even if computer systems almost can have too much information sometimes. EMRs. We see this. You go looking for something. It's not that easy to find it because you got to get rid of that. Got to get rid of that. Got to get rid of that.
That's right.
Right?
That's right. Yeah. Yeah. You could spend a long time looking for one little thing.
That's right.
Yeah.
Right. So I think it's something that patients aren't really aware of, They always get their discharge papers, but they don't really, is it kind of like, that information you get with your prescription that you're like,
Absolutely.
I don't think I'll read all that small print. And, right. So when they say, follow up with your primary care doctor in 3 days, they really want you to do that just because keep that consistency of care.
The expectation really is that the appointment should be scheduled at the time of discharge. I think that's a good goal for us to have. And again, I see an improvement with that,
Yeah, but we're not at that stage where I could just throw in an appointment. That would be great.
No, but with you and I, because we part of the same system, the care case manager, you could reach out to me directly, and
Right.
and the case manager at the hospital could talk to the care manager in our office. His name is Tom, a wonderful guy. He gets kind of a list, so part of his job is to kind of review it and make sure that things are in place, so to speak, for people who've been discharged.
Right. Patients shouldn't really trust. It's that thing, that old adage that you have to be somewhat responsible for your own care. So if you're being discharged from the hospital, make sure you realize who you have to follow up with.
I know, and it could be overwhelming, and sometimes it
Overwhelming
gets
'cause you're
rather
sick. Yeah.
So people are, they say they had a complicated case, a lot of consultants involved, right? Infectious disease, cardiology, pulmonology, nephrology. And a lot of times, again, I'm going to exclude Northern Dutchess because I don't think my colleagues do this, but when I get reports from other hospitals, they will just say, follow up with endo, follow up with the pulm, it's like, no wonder they're confused because this is, very, the plan is very complicated,
Yeah.
right?
Yeah. It's definitely overwhelming. Yeah.
I think people are listening going, yeah, why is this such a concept for the healthcare system to kind of say it's important that hospital experience communicate with the outpatient experience.
Yeah, and that the patient understands.
That's
I
right.
think that's key. And like you say, they have to take a little responsibility as well. Yeah.
Right. It's okay. And when patients call me or the family member calls me and just kind of gives me a little heads up that someone has been discharged. But I just want to say for people listening, though, that the communication between, my office and Northern Dutchess is really, goes excellent.
They're vested in you, Dr. Stanberg.
I just want to acknowledge what's working. We're all kind of pretty good at pointing out things that aren't working.
Yeah, that's true.
So, all right. So, tell us a little bit about things that the world of hospital medicine. What's new? What's hot in the world of hospital medicine?
Oh.
We did jump on a little break here, so I can you may have some time to think about that.
What's hot is COVID, I guess, is pretty
Okay.
hot.
COVID is hot.
It's definitely what's going on these days. And it's been a hard 2 years for hospital medicine. Definitely overwhelmed by the ever-changing, information about COVID and how we're treating, how we're handling patients with COVID. And, it's just been very stressful, obviously. That's apparent to everybody and stressful for everybody. So it's been strange because it's like, what's hot? And I don't really know because I have to sift through all that other COVID stuff.
Right. PC, pre-COVID. I mean, it's almost like, remember the quaint days prior to COVID.
Yeah.
When,
Yeah.
we didn't have to wear a mask all the time. As a matter of fact, Dr. Levine had an amazing birthday party, which was right before the dawn, COVID hit.
Yeah. Last time everyone was hugging and yeah.
We won't tell what year birthday it was. She could volunteer if she wants, but
It seems like yesterday, but boy, yeah. That's
Yeah.
right. That was our
Yeah.
kind of our last gathering.
3 days later, we shut down.
amazing. And we had a great time that night because we went out afterwards to the after party. We had a good time.
Where was the after party?
Oh, we went to our friends band over at the High Falls Cafe.
Oh,
We're gonna go
that's
to our first
awesome.
break. And we'll meet you back after that.
I didn't know about that.
Sorry.
Okay, and you've got Robin Baker and Dr. Eric Stanberg and Dr. Elizabeth Levine with us today. And you're with us here at KCR, Kingston Community Radio, AM 920, 92.5 FM. My name is Dan Gatis. It's 7:30 a.m. on this Monday, February 14th. Happy Valentine's Day. And it's 11 degrees out right now, so I'll be right back.
Do you know who that is? Who's that? It could be a clever thief impersonating Central Hudson, asking for your personal or account information, or an immediate bill payment. Beware of scam artists that can target you by telephone, email, or in person. Don't provide personal information to callers or open email attachments. Ask to see ID. If you're ever uncertain about an inquiry, contact us. Don't fall victim to a sinister scheme.
Everyone is talking about healthcare these days. America spends twice that of other developed countries on our healthcare system, yet our health ranks near the bottom. How can we stop spending so much and getting so little? By shifting to a system that gives more patients access to strong primary care. Primary care can help make America healthy again. To learn more about the benefits of primary care, visit www.healthisprimary.org. This message is brought to you by America's Family Physicians.
Hi, this is Cameron Rylance from Kingston, and I support Kingston Community Radio because it's informative.
And thank you for listening to KCR, Kingston Community Radio, AM 920, 92.5 FM, and streaming online at mykcr.org. Monday, February 14th, Valentine's Day. We'll all be doing something very, very loving today. That's a great thing. Keep it going all year. Abundant sunshine today with a high of 23. And we're starting out with a temperature of about 11 degrees right now. Tonight, mainly clear skies with a low of 9. And Tuesday, it goes up to 32 degrees, sunny along with a few clouds. Tuesday night, clear to partly cloudy, low of 14. And Wednesday, up to 44 again. Warming trend Wednesday and Thursday. And like I said, a high of 44 with partly cloudy skies. Wednesday night, cloudy skies with a low of 38. And this upcoming portion of Kingston Community Radio is brought to you by Central Hudson. Now let's get back to the on-air studio with Robin Baker, Dr. Eric Stanberg, and Dr. Elizabeth Levine. Welcome back.
All right, welcome back to the second 30-minute installment of this morning show. The second quarter, right? The Super Bowl here. We have 4 quarters. And a halftime show, by the way, Robin will be rapping.
Oh, yeah. That'll be
Presents.
great.
Oh, you brought a song in to rap. Okay, good. That's fantastic.
Not rap presents. Robin, oh boy, we got an old crowd here in the room. No rapping. Did you guys the Super Bowl yesterday?
It was a great halftime
Did you
show.
like it? I loved it. I
Yes,
thought
I
it was
loved it, too.
amazing. It was the best one.
Although we were arguing about who it was. We were like, that's Kendrick Lamar. No, that's Jay-Z. We were,
Chasey wasn't there.
he was in the crowd. He was in the crowd. And they're like, this young music. The rappers are all like 50 in their 50s.
They're our age. No, I thought it was wonderful. And it was a good game.
It was a good
They
game.
did better than expected, I guess.
It was a good game. Yes. And that's such a big part of our culture, by the way. Anyway. So, Doctor, we're talking about the PC era, pre-COVID. That's what PC stands for. And Dr. Levine had a amazing birthday party right before the curtain fell. But really, it's been a long 2 years in the hospital for you guys. And what do you think? Where do we stand? What's your how you reading the tea leaves or the trade winds? How many metaphors you need to get this conversation going?
Well, if this were 3 weeks ago, I probably wouldn't be in this room with you because I'd be more afraid and also maybe too stressed out to even do this. The past month has been a scary time just because not only did we have higher numbers of patients with COVID, we had staff who were out because of COVID. And it was just tough, to watch our community also get sick and how do we protect ourselves. So it was difficult. But we feel better now, like in a matter of a week, it kind of flipped, and we have
as quickly as it turned on, it kind of turned off.
Kind of did, but it didn't turn off. We don't want to say that.
Maybe it's a bad analogy.
We still have patients with COVID in the hospital. Certainly, still super vigilant. We wear N95s, like.
Right.
This is radio, right? But
Well,
it's sort of. I know. I don't want to. So we wear N95s all day long, still. To protect ourselves and our patients and each other. And so it's still, a big issue, but we're feeling like it's not as intense as it was.
Yeah, I mean, the Omicron surge, that's what I meant with it, kind of like as abruptly as it showed up, it kind of went away, but we're still dealing with the aftermath of it. Although I'm looking, without getting into details, I think your census in the hospital now is down to about a quarter of what it was, just a couple weeks ago. So that's a very good kind of delayed indicator of COVID and how it's affecting us. But another surge might occur. I mean, a couple thoughts. So we talk about this on the show. The idea that the virus may be and is hopefully mutating. What's the word we use? Called mutating? No, whatever. To a form that's less virulent. So. And I think we're going to be a little more prepared for this, the next surge if it happens. I think testing will be more widely available. It really did, catch us kind of blindsided, And there's some new treatments now, which I have prescribed a couple of times. Excuse me, which is the medication called Paxlovid, which is is going to become more widely available if and when we have another surge. So those are a couple basic game changers if and when it happens again.
Yeah, I'm happy to hear that you're able to do that. We don't do that.
It's only been a couple times because by the time it became widely available, the need for it had subsided a little bit. Do you have any thoughts about the many patients you've taken care of? And I'm sure you've taken care of some sad cases. Any correlation between we're not going to get political here, but just facts or that's the wrong. Who put me in charge of this show? I'm not facts, but what's your thoughts about the correlation between or the value of the immunization and how it affects the people sick with this illness?
Yeah, I mean, I'm very pro-vaccine. So what I've seen is that people who are not immunocompromised and vaccinated, if they get like Omicron, it's a milder case. Right. Those people don't tend to be hospitalized as much. Some are, though. It's not, it's not
cut and dry. It's
yes,
not like
thank you. Mm-hmm. Thank you. And but people who are not vaccinated who came in with Omicron, a lot of them were very sick. I mean, remember, I'm seeing hospitalized patients, so right. They're the people who are sick enough to be hospitalized. So when they weren't vaccinated, they didn't do well.
Yeah, my own informal review of the cases, they usually, there were a couple of basic categories, people who were not vaccinated. There were a few people who got one dose, were not completely vaccinated. I thought it was common to have people not be properly boosted. People got the initial wave of vaccines in January, February of 2021, but, the booster kind of was sort of be recommended around November, and, for whatever reason, they just didn't get around to doing it. I thought that was a common one, too. Mm-hmm. And then, yes, the fully vaccinated people who were sick, there seemed to be something. There's an underlying disease process like multiple sclerosis, or just what we call the super elderly. People 80s and 90s and upward. So I looked at that kind of my own informal review of the cases and really saw value in not just being vaccinated but being fully vaccinated and fully boosted. So I don't want people who are still not there yet to say, oh, Omicron's gone, we don't need to worry about it now. I think you should still get yourself vaccinated if you're not vaccinated, and if you're not boosted, you should get boosted. I've done it. Robin and I, by the way, are fully vaccinated and boosted, but we got it. We got it about a month ago. Knocked us out for about a week. It wasn't horrible.
Right. Well, and your mom got it in a skilled nursing facility. She was asymptomatic, thank goodness, because she's quite elderly. But
it was weird. We were sick and she wasn't.
Yeah. But I didn't want to get it. I was very upset when I got it. I mean, it was a long 2 years of really striving heavily to to avoid getting sick. I just didn't want to get sick, and it was upsetting to actually get sick.
I know.
So I was grateful to be boosted, and I was grateful that it was a mild case. But, we've lost some close community members and family members to this. And I work at a restaurant as well. And I just yesterday had a conversation with someone who said, oh, it's just like the flu. It's exactly like the flu. And I was like, well, it's really not. Except for 100 years ago, the flu never killed like 1 million people in a year. So
it is about 5 to 10 times more deadly than the flu.
Yeah. So
if you look at death rates.
That complacency where it's like, hopefully it won't affect you. I hope it won't affect you. I hope it won't affect someone you love. But the truth is that we've come a long way in 2 years. So we know a lot more than we knew initially, obviously, right? Because it was a new virus and nobody knew anything. But, I mean, the doctors are here in this room on this radio show saying, this is a good idea. Please do this. So hopefully that's resonating with our listeners.
We're trying. I have had a few patients in my practice pass away from COVID, and they fell in those categories. Not vaccinated, under-vaccinated, or just underlying immune system. One woman was in her high 90s, her age. So
Yeah.
But it was, it's also, by the way, and unfortunately Dr. Levine knows this very well, a really miserable way to
pass away.
Yeah, I've seen many more sad endings with COVID than sad endings with flu.
Right.
And many of the people who were not vaccinated who ended up getting critically ill were really sorry they didn't get vaccinated. So
that's hard to see, isn't it?
Yeah. Yeah.
It's in a way, people make decisions that are not always the right one or the ones in their best interest. But, some patients kind of say, I made a mistake. I really want people to get the message out. There are other people, at least throughout the country, who just kind of dig in heels even deeper. It's that really has affected healthcare providers too.
Yeah, we've had a few of those. Yeah, but I had it as well. I had COVID 2 weeks after my second vaccine. So in theory, I was supposed to be, protected, but I was because I was hardly sick. My mom had it. I had a quarantine with my mom for 10 days, which was interesting. She's 94, and Eric is her doctor now. And
he's a pleasure. She is.
She is.
She's sweet and funny.
Too bad we can't have her here. She would sing for everybody.
Talks a little Yiddish.
But
dances, she sings.
She does. But I think it's important to say that I know that Robin and Eric had it, and I wouldn't be sitting here without a mask if I didn't feel safe amongst us all, because I feel like we're just safe with each other. But if I didn't know you, I would probably have my mask on. So.
Well, we might segue a little bit over to that, but the governor did lift the mask mandate for many places, and I don't think she's getting fed misinformation there. I think she's being advised and getting accurate information that, at least for now, we're going to lift the mandate, and I'm okay with that. I still want people to get vaccinated if they haven't been vaccinated, right? So I have faith in that. I can't have it both. You know what I mean? I don't want to be skeptical. I want to have that. I want to have faith here. What do you think, Robin?
Well, I think a lot of people were like waiting. Remember we talked about that on the show a lot. Like, well, let's see how everybody else does.
Yeah,
yeah, that's right. I want to see. That was weird.
But if you were waiting to see how everybody else is doing, just be encouraged that yes, people get less sick.
During Omicron, the number of people, at least in our district here, was enormous.
Yeah.
Every human on the street, in the stores, in the restaurants and everything complied right away. Right away. It did very, very well. And I think that had a lot to do with, subsiding it.
Coming out the other side. Yeah.
So I am cautiously optimistic for the spring. And, a little tease last week of some nice weather. So, maybe we'll be able to walk around uptown Kingston. And you, by the way, Dr. Levine lives in uptown Kingston. So
I do. I'm a Kingstonite now. Is that what they call us?
Kingstonian?
Oh, no.
Kingstonian.
Kingstonian, I would be a building, a proposed building.
It's a building.
I'm not a Kingstonian.
Right. Somebody call in with the correct verbiage.
Kingstonanian?
Kingstonite? We're going to be in so much trouble.
Yeah.
Kingstoner.
Kingstoner.
So I want to say that I think that the masking is not a big deal, and I think we should continue it until I'm not for the lifting the mandate.
You're a little more. You think we're moving a little too fast?
Yeah, I feel like maybe when we can be in the hospital and wear a regular surgical mask might be the time to think about, you know what I mean? Like, I'm still...
Are we sending a mixed message? Like, I'm going to go to my office today, and the mandate has not been lifted for medical sites, so you're kind of saying, hey, what's going on here? Either lifted or not lifted if you really think it's time.
I think we'll always be wearing surgical masks.
It might be a new normal, where whenever, or at least whenever we have a potential infectious disease. The ideas of going to see someone with the flu, in next January and not have a mask on. I think
that's over.
That's over. I think
Yeah.
These are kind of new standards for us, right?
Very much so. Everything's been new for 2 years.
I know.
I want to give a shout out to the members of Dr. Levine's department and the staff of all the hospitals, nurses and support staff, and then the various consultants that have also been working tremendously hard. The infectious disease doctors and pulmonology, intensive care specialists, which are usually kind of pulmonologists. Sometimes the terms confuse us a little bit.
So I'm part of the well-being at the hospital.
Okay.
So you might like to hear about that. That we have a committee, but we do several kinds of programs for well-being for the staff. Because
give us a context. You know what I. Again, who put me in charge of the show? I cut her off. She was about to tell us.
That's okay.
What?
You're
doing great. Keep it up.
There's confidence problems.
What do you mean that, like, why would you need a well-being?
Yeah. That's what I was trying to add.
Yeah.
She was starting to tell us, and I interrupted her. Go ahead.
So, as caregivers, nurses, doctors, everyone in the hospital, environmental, housekeeping, all these people are caring for patients in the hospital, whether directly or indirectly. And oftentimes we're not thinking about caring for ourselves. Yeah. Right. So we have several different ways that we incorporate, the importance of thinking about ourselves as well, and the fact that we could be better caregivers if we care for ourselves first. We have something called Schwartz Rounds, which you are a part of, which is, it's done like every other month, and we have a topic where sometimes we talk about a difficult case, And we have panelists, and my colleague Martha Haig and I facilitate the panelists, and we get to the emotional side to what the panelists are feeling about the topic or the patient. And it's really uncharted territories in a lot of ways because we're not used to talking about our feelings at all. So it's been amazing. I love the whole theory around Schwartz Rounds, and I really love doing that. So that's one example.
Yeah, the history of the Schwartz Rounds is kind of worth telling people about. The term, where's it come from?
Yeah.
Go ahead.
Ken Schwartz was a lawyer. He was in his 40s, and he worked for a Boston healthcare organization. And he sadly had cancer at a young age, lung cancer, and was really amazed by all the care and compassion that he got from the people who took care of him. So before he passed, he came up with this idea of having these rounds, that they needed to be, it was more like creating a space so that we can talk about, the emotional side, which is, a lot of things. It's stressful, but it's also beautiful, like not only have we witnessed really difficult things, but we witness beautiful things too, like even taking somebody to the end of their life in a beautiful, peaceful way is a beautiful thing. So he left a really great program, and it's a center. They do amazing things. It's international.
So, Schwartz Rounds, are they usually monthly?
Every other month.
Every other month, yeah. and I have attended a few, and they are kind of interesting and special. We're really not allowed sometimes to really sit back and take stock of how we're feeling about something.
Yeah.
That's a godsend. It's an absolute godsend. That's what our World War II and Vietnam vets experienced. You've got emotional trauma, and it wasn't, you just suck it up. And you guys do it a lot. And this is a way of, especially during this era of COVID, must have been extraordinarily important.
Yeah, and it's meaningful stuff. I was able to be a featured speaker, or whatever you want to call it, at one of them. And I was
panelist.
Talking about a gentleman who did not pass away, but just the difficulties helping take care of this patient and other things. And, it was I enjoyed it. It was interesting. And by the way, it'd be nice if we had something like that on the outpatient side. That's your purview as well.
Yeah.
But the same thing happens. We use the term burnout is used a lot, disconnect, disengagement. But one term that does get thrown around, and you're probably familiar with this term, is moral injury.
Yeah, like I don't like the word burnout.
I think it's right. Burnout kind of like, we don't like it because in a way it kind of implies that we're the problem. We burned out.
Yeah.
And by the way, burnout applies, and I think about this, not just about doctors and nurses. I mean, I know teachers, I know police officers, people in businesses. It is kind of a human phenomenon that affects everything, so. But at the same time, I do feel we should have relatively high standards in healthcare. So one phrase Robin has heard me say is saying, if we can't take care of ourselves and each other, perhaps we should reevaluate our ability to take care of others.
Absolutely. Yeah.
Anyway, so the more term moral injury, what do you think about that term?
Well, I know when I feel, quote, burnt out, unquote, is when I'm feeling morally not aligned. So like if, let's say, Medicare comes up with a new rule that is coming down at me, I feel off. Like I'm not at my center. It's maybe something I don't believe in. And so that creates this kind of moral injury.
Right. I mean, I think its most severe case does kind of have a military context, which is why I thought about it. It kind of refers to someone who, maybe joins the armed services, to serve their country, and but then winds up taking part of things that are hard to reconcile. We saw it a lot with the Vietnam generation of veterans, and I think we barely even touched the surface with the people who served in Iraq and Afghanistan. amazing how we're letting history kind of repeat itself again with this. But the idea that it extrapolates over to healthcare, I understand the sentiment. I like the term moral injury. Sometimes when I feel like comparing it to what someone who went through in Vietnam, I think the comparison, starts to wilt a little bit, because it's a big jump.
Yes, it is.
But yes, there's a lot of what I do all day long, which is not directly related to taking care of my patients, and that has affects things. I'm supposed to click some boxes to make so data can be tallied. I prescribe a medicine. I now have to do something to get that medication covered, even though I've already prescribed it.
Right.
Prior
approval.
Yeah, prior.
There's nothing that causes moral injury more than that for me.
Right. Prior author. I happened over the weekend where I have a patient who was recently diagnosed with prostate cancer, and he's an elderly man, and it's advanced, so he's failing. And something about his home services was just they reviewed it and decided he didn't meet criteria. So now the responsibility for appealing that is on my shoulders.
Yeah.
When first of all, no one's really asked me. If they called me, I'd say, yeah, he needs this, but so that kind of like being part of a system that's not making sense, really does weigh on.
Yeah, it's interesting because it's like when I feel not morally aligned myself, but also when my patients are not in alignment with what they need, let's say, because somebody's saying they can't have that.
Right. That's right.
Well, it's almost always the person who's holding the purse strings that says,
exactly,
no, you're not allowed to have that.
We have a couple themes we always reinforce. One is if something goes wrong with a test that was ordered or a prescription, to really understand where the difficulty is coming from and realize that your doctor or prescriber is on your side. We're the ones who prescribed it. So when people kind of get worked up and take it out on the doctor's office, that can be very upsetting. And so we really discourage that.
Yeah.
Billing as well. I say to people, you get a bill that, something might have been covered, now it's not being covered. I always say just take a deep breath.
Yeah.
I'm a pretty busy guy, but I'll look at the bill, and usually it's something that is easily remedied, Or unfortunately, it could be part of a plan that people just don't understand. Like
I just got a bill. I think I'm going to bring it to you.
Yeah, I'll look at it. Well, we do have deductibles, high deductibles. And it's complicated. Where I work, they give us two variations of health plans. One costs a little bit more than the other. I'm not quite sure. Beyond that, when I'm looking at the list, this is 80%, and that's 70%, and it's complicated.
Right, so think of the layman.
Oh my God!
Yeah.
You guys are doctors.
We're struggling to understand.
It's terrible.
I know.
I don't know how people do it. Every time I call like a doctor's office, I just wonder, how do patients handle this? Me being the patient, I'm saying I can't believe how
we encourage
it
people
is.
to realize that the doctor's office, is on your side. We talked. One of the original subjects we had was triangles. We talked about how, people in the therapy world, those are dysfunctional relationships. You think of a teenager who kind of working both parents against each other. Making a triangle. So in the healthcare system, it's a third party system.
So
So you have the patient, you have the provider of the service, and then this third entity that kind of pays for the service.
Mm-hmm.
And that's just kind of inherently dysfunctional. So the fact that one end is starting to cause problems, but the other two components start fighting with each other, is just part of the dysfunction. Robin did it for a while.
The medical industrial complex.
Yeah. I can tell you what the problems are. When I start thinking about what the solution should be, I start kind of, I don't know.
It's easy to point your finger and
say,
that's wrong.
We shouldn't have third party. Well, then we would have people who really couldn't afford any care, So we need to have something in place to cover the cost of medical care.
Yeah.
Although I also think about like calcium scores. Calcium scores is a test that a cardiologist or a primary care doctor might want to order to see your risk of heart disease. And for reasons that I don't understand, it's not covered by insurance.
Not covered.
But as a result, though, the cost of it kind of went down.
$75.
$75.
It's
So
amazing.
people can, choose to pay for it themselves, and it's affordable. So when you get the third party out, that kind of brought costs down. So that also kind of a little eye-opening for me.
Your hands in the air.
I can't figure this out.
Can we talk about end-of-life care and palliative care when we get back?
Yes, we're going to go
We're
over
going to
next.
do birthdays, too.
Yes.
And we'll set up Dr. Levine with her bells.
Yes, we will. We'll get her bells
Very
on.
exciting birthdays
All
around
right.
here.
Good.
Okay, and you're with us here at KCR, Kingston Community Radio, for the top of the hour break. And many thanks to you for listening. And you are listening to Kingston Community Radio, AM 920 and 92.5 FM, and streaming online at mykcr.org. Monday, February 14th, happy Valentine's Day. Do something special for yourself and your loved ones. It's 11 degrees right now here in Uptown Kingston, and this last portion of Kingston Community Radio was brought to you by Central Hudson, and we'll be right back after these messages.
This is what carbon monoxide sounds like. Nothing. You can't see it or smell it either. That's why it's so dangerous. But you can protect yourself. Use carbon monoxide detectors. Have your home's heating system regularly inspected by a trained technician. Keep chimneys and flues free of debris. Never use a generator or grill or idle a vehicle in an enclosed area. And review life-saving carbon monoxide safety information at centralhudson.com.
The possibility of lung cancer can be pretty scary, especially if you're one of approximately 8 million current or former smokers at high risk. That's why SaveByTheScan.org wants you to know that now there's a breakthrough low-dose CT scan that can detect lung cancer early, and it only takes 60 seconds. You stop smoking, now start screening. For an easy quiz to see if you're eligible, visit SaveByTheScan.org. It could save your life. SaveByTheScan.org is brought to you by the American Lung Association's Lung Force Initiative and the Ad Council.
Hi, this is Dina Roy from Hurley, and I support the Kingston Community Radio, and so should you.
You're with us here at KCR, Kingston Community Radio, AM 920 and 92.5 FM, and streaming online at mykcr.org. It's Monday, February 14th. Happy Valentine's Day. And it's 11 degrees right now here in Uptown Kingston. And we're going to go up to 23 degrees later on today with abundant sunshine today. Mainly clear skies tonight with a low of 9. And we jump up to 32 degrees on Tuesday with sunny skies along with a few clouds. Clear to partly cloudy on Tuesday night, and Wednesday, partly cloudy skies in the morning give way to cloudy skies during the afternoon with a high of 44. And Wednesday night goes down to 38 degrees with cloudy skies. And let's get back to the on-air studio now. Oh, by the way, the upcoming portion of Kingston Community Radio is brought to you by Herzog's. Stop by Herzog's Home and Paint Center in the Kingston Plaza for all of your home building, maintenance, and painting needs, and discover the difference of buying local. You can also go online and look at their sales. There's always ongoing sales at herzogs.com. Okay, let's get back to the on-air studio with Dr. Eric Sternberg, Robin Baker, and our guest, Dr. Elizabeth Levine.
All right. Well, welcome to the second half of this morning's show, after our halftime show. By the way, he just announced Dr. Levine.
He did, so you don't have to do it again.
Our guest today is Dr. Elizabeth Levine, and now we're going to do birthdays. Oh, so this is the high point, not just of the morning, Dr. Levine, but the week. Here we go.
So it's Monday. Well,
I don't have to do that.
These are Valentine's Day birthdays.
Yes.
That's something else.
This is March 14th.
I have a feeling that might be a...
Is that
I don't think they come in that early.
Okay, so we're thinking that even though it says on this little piece of paper, March 14th, that it's actually Alana Tenor's birthday today, which is February 14th, Valentine's Day. And this is from your friends and family, Mom and Dad, Landon and Lucas, Graham and Gramp Van Valkenburg,
Wow.
and Great Graham and Gramps Craw. So happy birthday, Alana. I don't know if I'm saying the last name correctly. It's spelled Tenore. I think it's Tenor.
Tenor?
Or Tenor?
Tenore?
Tenere. But if I'm saying, forgive me for saying it wrong, but happy
Well, if you're
birthday.
listening, call in and tell us how to say your name, and we'll say that's it. And we want to wish a happy birthday to Ed Herwig from your friends at People's Place. We hope you enjoy your special day. So, Robin, today's winner will win what?
We'll win a famous cow pie from Boy's Dairy Milk House at 62 O'Neill Street in Kingston. And do you know what a famous cow pie is?
You asking me? Or
I grew up on a farm, so cow pie is like that thing we don't really talk about too much. But it's just
thing on the ground.
Instead of an ice cream cake, it's like an ice cream pie. And you can choose what kind of ice cream you want, and you can choose your toppings. It's kind of like a big sundae. So it's really exciting and wonderful present. So the winner of the birthday for today, February 14th, is Ed Herwig. And you can go to Boy's Dairy Milk House today, 62 O'Neill Street, and claim your prize. So exciting.
All right. Dr. Levine, wasn't that exciting?
It was. I thought people were going to win a cowbell.
I do sometimes my Christopher Walken imitation with that, though. I need more cowbell. That's the... All right, so Dr. Levine, in addition to the many hats she wears as the director of the hospital medicine program and also the facilitator of Schwartz Rounds, one of your areas of interest and focus is on end-of-life care. Can you just tell us a little bit about that? You know, why you think it's important, and how we should approach it?
Sure. So, I guess, let me see how I'll start. Working at a nursing home opened my eyes to end-of-life care, obviously. I think that it was an experience there that I had with several patients, taking them through to the end of their lives and keeping them there and really working on making that time for them the best that it could be. So that was probably the start of it, my interest, that it's possible to enable somebody to have a decent exit, I would say. And I got interested in death and dying. My dad had dementia for about 20 years. Initially wasn't that bad, and then it just progressed to the point where he was, pretty nonverbal in a wheelchair. And that, from the start, as his daughter, who's also a physician, I wanted to be sure that he didn't go through anything that would be extraordinary, because his life was going down that path where it was difficult, and it was hard to tell if he was actually suffering. So I got into it from that perspective too, as a daughter of somebody who had dementia. Now my mom has dementia. I just think it's really important for people to think about what they want at the end of their lives and for their families. And I also just got interested in just death and dying. Suddenly it occurred to me that it's going to happen to all of us, and just being really open with patients about talking about it, basically.
Right.
Yeah.
Do you think that Medicare has helped open the discussion by kind of requiring the MOLST form to be filled out? And this is something that you're talking about at your doctor's office that, you kind of never did before. And maybe kind of at a younger age than maybe you would have ever talked about it. People have a hard time talking about it.
Yeah. I don't know what's good. I know through Eric, because we started a group together to try to make it better. I don't know, is Medicare requiring, or it's part of your Medicare visit?
I think the MOLST form comes from the state, although I think
it is from the state.
I know New Jersey. My brother works in a senior-related capacity in New Jersey. They have a similar form. Medicare does cover end-of-life counseling, but in typical Medicare fashion with strings attached. So they will cover it, but it has to be time, and I have to spend at least 15 minutes talking about it. And that's, depending on the patient, kind of a long conversation. If the idea is to get someone who's maybe 68 to start thinking about it, that's not really a 15-minute conversation.
No.
So
Yeah.
and then you also know that my biggest commodity that I have to offer people is time. So there's only so much to offer. So so it's a good example of kind of covering it, but not making it easy.
Yeah.
Which
Yeah.
unfortunately is a theme about what happens a lot.
Is it part of your annual well-being visit for Medicare?
It is. Again, press for time. We're working on a system that's going to involve, I mentioned Tom earlier, our care manager, to assist with that as well. So
Yeah.
we're hoping to kind of reinforce that and make it a more, I always bring it up, by the way, at wellness visits. It's just the intensity of the discussion is varies. Again, a 66-year-old is different than an 86-year-old and
Right.
things like that.
Yeah, like for a 66-year-old, I would jump in. Well, for everybody, I jump into like a health proxy first. In the hospital, whether it be in an office, you just like, who would your go-to person
Right.
be? Have you thought about it? Do you have a health proxy? So I usually would start with that, and then the most form, it is New York State and many other states. Maybe there's 13 other states that use most medical orders for life-sustaining treatment. It was really meant to be for in the last year or so of life, or if you're in a facility, or if you have opinions about, like my 94-year-old mother, if she could completely make her own decisions, she would say no, even though she may not, she's going to live to 100 and whatever. So if you know what you want or don't want, like I'm 90, I definitely don't want to be on a respirator.
Right.
Then you can do a most form. So that's what it was for. So the idea that someone like Medicare would say to fill this out, I don't think is the right use of it, I guess.
Yeah, it's meant to be a discussion. It's an optional discussion, by the way. When it was first proposed around 2010, there were allegations of death panels.
Yeah, right.
It was really just a discussion, and
That was sad to make it into that. That really made me mad.
And then, I do get some resistance from patients. They just don't want to think about it. It's an uncomfortable subject. So, in my precious time of my office visit, I sometimes have to triage and move on to the next subject.
Yeah, absolutely.
But we are working on a system that will include the resource of our care manager. It's one of his interests as well. So we'll look forward to kind of changing that. But yeah, it's and there's three things, and maybe people are confused about this. You got the healthcare proxy, you got the living will, and then you have a most form. And the reason I think people are confused is there is a little crossover in all these things, right? So the healthcare proxy I define as the appointing of someone to make medical decisions for you in the event that you cannot make them for yourself.
Perfect.
And I think New York State does have kind of a pecking order. It's good to have one in place, but I think New York State allows it to go to the spouse, and if not spouse.
Yeah, if somebody, so if I cannot make my decisions and I did not designate a healthcare proxy, New York State has a surrogate law,
right,
that will appoint, spouse, kids. There's. Unless you have disability, for people with disabilities or mental health disorders, that's a different.
That's kind of its own topic in a way, because
it
that
is its own
sometimes leads
topic.
to drawn out care that also is futile, in many cases.
Yeah.
So that's the healthcare proxy. The living will is people sometimes say, yeah, I got all my finances in order, and I say, well, that's not the type of will we're talking about. And maybe it's a weird name, the living will, But that's that's a document stating your wishes. I don't want to be left on a ventilator in a prolonged condition, or I don't want to have a long-term feeding tube in my abdomen. If I'm in a persistent vegetative state, I authorize that care be stopped. Things like that, right?
Mm-hmm.
And then finally, get the most form, which is a little. Doesn't really have the healthcare proxy, but it does kind of have some space for living will type stuff to be written in there too on the famous page 2.
Yeah, I would call it's more of a directive and order.
We got advanced directive is one more term to throw in there.
Yeah, well, that groups them all together.
Right.
So, But the most is more of a directive. Like, this is what I want. This is what I don't want.
Right.
I want CPR. I don't want CPR. I want to be on a machine. I don't want to be on a machine. I want a feeding tube. It's pretty clear. And when people are ready to make these decisions, I think it's not a bad document. I think that it works pretty well. And they're orders. They're like me putting in an order.
You're supposed to, it's a pink form, which is also interesting because at the same time we were supposed to be scanning everything into the computer, so no one really knows where you can recognize the color pink. Some forms, I guess, scan in colors.
Yes.
But you're supposed to bring it if you ever have to go into the hospital. It is supposed to be reviewed by your whoever's admitting you, and they co-sign it that it's been updated. Unfortunately, it says if you want to change the terms, you have to, do a whole new form, which, as you know, our enemy is time, and that takes time. It's also a weird form that asks for the names of witnesses, but not the signatures of witnesses. I always thought that was a little weird, too.
It is weird.
Yeah.
Yeah, but I like it because then I just
right.
say, hey, can I use you as a witness?
Someone's walking down the hallway.
It's kind of like an insurance policy, though, don't you think? Does it facilitate things in a hospital setting as far as like families fighting and things like that? I mean, I've always kind of looked at it as like, you don't want your house to burn down, but everybody has home insurance. You know what I mean? Like, you don't think you'll be in a car accident where you can't speak for yourself or you can't make decisions for yourself. But if you ever were put in any kind of situation accidentally like that, if that did happen to you, got stung by a bee, couldn't talk for yourself. So-and-so is going to speak for me, and then these are my wishes. So it's written down. So it was like in place, like as far as a conversation, like in kind of like an insurance policy. Think of it that way. I mean, I've just been in certain, I think people in general can relate to their own personal, right? You can relate to your own personal with your dad and stuff, but like someone ends up in the hospital and then no one knows what to do for the person because no one really asked the person what they wanted. And, Aunt Sally thinks this is the best way to go and the children think this is the best way to go. And there's like, so you're kind of avoiding all that if you can write down your own wishes ahead of time.
Absolutely. Well, it's perfect what she just said because that situation for us in the hospital is really uncomfortable. Not that it's about me being comfortable or not, right. But it's, my goal is to do the best for the patient. And if that wasn't sorted out, right. If somebody's 90 and clearly has chronic medical problems and all that, and nobody ever talked about that, makes it very hard. Like, what do we do? And then, you have all these people coming in with different opinions and all that. The best scenario is when the patient has stated what he or she wanted and that you go along with that. It brings so much power to caring for the patient.
I mean, we have had stories where sometimes the healthcare proxy starts to kind of, not enforce the living will or kind of goes against what we see, in writing in front of us. Yeah. And that could be, that makes some difficulty too. So choose your proxies wisely.
Yes. Yeah. And the living will is, it's just guidance in New York State. It's not like the most. Most is
in order.
Yeah. So if somebody, the living will is helpful to say in the circumstance that you mentioned, look, your mom stated that she didn't want to live in pain. She didn't want to live, like if she had memory loss, she didn't want to prolong her life. And so living will is kind of like guidance.
Right.
So it's helpful to show families that, but with most form, when families go against it, that's tough, and we usually have to get the ethics committee involved because it's going against what somebody wants.
When I'm in the office and I'm trying to encourage somebody to complete a MOLS form or at least think about these things, I do say, Saturday at 3 a.m. in the emergency room is really the wrong time to resolve these issues.
Yeah, and that's what we're trying to do
Right.
in our advanced directive group is patients should have these conversations with the doctors they've had, for years, or APPs they've had for years. They should have those conversations.
And I should clarify, Medicare does pay for it, and actually, what they pay is reasonable. It's just you have to also make time for it in the course of a day, so that's the drawback.
Yeah.
And again, not every discussion is the same, so.
So that's confusing too, because I thought that the most was required.
No, I think, a practice, you might choose to encourage everyone to complete the most. But again, I'm not, I always use the analogy of, I have many 66, 67-year-old patients on Medicare who are unfortunately in better health than me, so it's just a different discussion. And the most is just, they could do it, I guess. It's just, it's really.
Yeah. I think at that age, it's good to have the health proxy and to encourage the patient to have conversations with the healthcare proxy about things, right?
Yeah, and I have a couple times where I bring it up, and I say, I know about these patients. I know that they're married, but they've been separated for 10 years. So I kind of try to say, if your partner is this person now, but you're still married, you better put your healthcare proxy in writing. And there are some other times where I've kind of, certain partnerships and unions where they're not actually married, but they're very much each other's life partner. I also say it's very important to make this a healthcare proxy as well. And, so there are times where, I understand the nuances of the patient's life story, and I encourage, to prevent, someone else from showing up in the ER and then pushing aside the person's, loved one. It doesn't really happen in New York that much. I imagine it might happen in other parts of the country, unfortunately.
Well, now it doesn't happen in New York, probably. Yeah.
Right. And it's a big state, by the way. We're just taking our own experience of what we've had. I've never seen it happen, but I've spent my whole career in the sheltered world of Kingston and Rhinebeck, so.
I trained at St. Vincent's in the midst of the AIDS crisis, so I saw it a lot. A lot of, suddenly families coming in and, taking over, and it was really painful to watch. People had partners and they just lost their power to help. It was horrible. Yeah.
And even a legal expert once told me that New York doesn't even really have a common law. Have you ever know anything about that?
Yes, it's absolutely true. There's no common law marriage. Like, for instance, I think California has that. After 7 years, you're considered legally married.
All right, so it's a little for people listening. If you're in a situation like that, or you know anyone, it's another good reason to have a healthcare proxy in place. So, what are you trying to do at the hospital front to encourage this? Because I work these shifts too. I mean, time is still our commodity. It depends,
Well, we're trying to educate nursing to help also with definitely obtaining the health proxy, especially with COVID when visitors were limited. They're still a little bit limited, but it's better. We didn't know necessarily who to speak to. And, they'd have emergency contact, but that may not be the person who is able to get the healthcare information and maybe even make some decisions. So trying to get healthcare proxies on everybody when they come in and teach other staff how to do that. And by the way, they're not hard to do. You don't need an attorney, or you just need... you can do this at home. You print off the sheet and you get a witness, and that's all you need.
I have those forms in my office rooms that I give to people, and I say exactly that. You can hire an attorney if you want, but you don't have to. New York State does not require it. You just complete this form.
Yeah. But also in those cases where people are chronically ill, certainly if it looks like, a year ahead, they will... their lifespan is maybe a year, let's put it that way, then I'm trying to get people to work on getting these forms from these patients and their families. A lot of people have them, and we don't have them, so we need to do that. But I'm just trying to make it, I think if we make it like a normal conversation, then people won't shun it so much. Mm-hmm. I think that death is inevitable, and everybody, when people have a hard time talking about it, I go deeper with them. I'm like, well, tell me, like, what are you afraid of? Why are you afraid of talking? Not why, but what's going on? What are you thinking? I try to get deeper instead of just pulling away and saying, not for that person, because it helps people. It helps people to go to that place of discomfort to eventually say what they want.
At the risk of maybe overstepping, but I understand. I mean, I was an attending physician over at the former Benedictine Hospital for many years as well, a Catholic hospital, and there was no opposition whatsoever to healthcare proxy, living will, end-of-life care. So when that kind of comes up in the context of Catholicism, for example. Again, I'm an outsider. I don't want to. All I can tell you is I didn't experience that from the nuns and the priests that were very involved with Benedictine Hospital.
Yeah, I think it depends where you are. St. Vincent's was the same. I felt. Yeah, it depends. I mean,
when
there are some religious organizations around that don't honor most.
When Pope John Paul, but okay, I got you. I know where you're going with that, but we won't mention it. But Pope John Paul, though, passed away, and I remember it was 2004. So around the same time Ronald Reagan passed away, he basically also became a terminal care patient. I mean, it was so long ago, I don't know if people remember that, but he basically went back to his a rectory? What are they?
You're asking me.
Papal estate, his papal house, and passed away. Said it's the end of his life. He was very ill for a long time.
Yeah, and it would be cool if people like that could teach others. Like that would be really cool.
Right, and I want to encourage people to think about it. But it is tough. It's people are very uncomfortable with the conversation, and in the context of a visit, there's a lot of other things to go over. So it's really just kind of like, all right, I guess I'm moving on to the next subject. I tried my best.
Robin's statement was one of the clearest that I ever heard as a justification and an encouragement to use to get all these advance directives in place. Something can happen to you at any time in your life. You can fall off a cliff. You can have a car accident. You can have a skiing accident or something like that, and you can be unconscious for days. And get it together.
Yeah.
Do it in your 20s and 30s.
Right. We would talk about it. I'm surprised. I was just because I worked in medical office for such a long time. I really thought it was one of those boxes that had to be checked off by Medicare, kind of like your mammogram and your colonoscopy and your things you have to take care of. Because I thought that you were being kind of checked on it in this corporate type culture. But Eric, you're kind of saying that's not true.
No, I think the office you worked at, Medical Associates of the Hudson Valley, was very, and rightfully so, very proactive in encouraging these forms to be completed, which is to the credit.
Right. So, yeah, that's kind of how they had the staff was trained to discuss it in that manner, as if it's, this isn't, you're not making life and death decisions. You're just saying that in case something happened to me, who would I want to speak for me if I couldn't talk for myself?
Yeah.
And, so, it's kind of, as we talk about, everyone will reach the end of their life. The chances that you may become ill or incapacitated for any reason, by accidental or otherwise, are pretty high, kind of like you have car insurance just in case of that fender bender. I think it's a good thing to have in place, like for your own well-being and your own,
And when it comes to point to like resuscitation, it's ugly. It's an ugly process, and sometimes, and I'm not really being serious here, but I almost want to like film one, and maybe put a
sure you could YouTube it.
Right, really? Okay, maybe
Probably.
And then protect someone's anonymity, but let people see exactly what's happening when the code's going on. And then, the room is full of people. You're kind of, naked to the world. The process of a tube may be going down your throat, someone pushing on your chest, maybe giving you electric shocks. I mean, it's and then the success rate of codes is it's not great.
It depends. I mean, in hospital is not great, but I want to say too that this the good and the bad, because surviving a code when you have a long life ahead of you, and maybe there's a reason why you needed to go on the respirator brief for a short time is a beautiful thing. Like that, having CPR does save lives.
That was a question actually that
I had a call.
Yeah, it was a question that a guy didn't want to go on, but he said he was a new caller. I didn't hear him before. He said that like, do you have that stipulation where if you know you're going to come out on the other side, that the respirator can be an option, but that if you're terminal, that you can say that you don't want the respirator. Can you do that?
You want to answer that?
Sure. So it's tough because a lot of living wills do state something like that. Like, I want everything done unless there's no chance for me to recover. Right. And a lot of times we don't know that. Right. So the MOLST form has something that says a trial of intubation, which is going on a respirator, or you could click off long-term intubation or respirator for long-term, so lifelong. So you can make a choice on this MOLST. So I would say in that situation, you might say a trial of intubation, and then if I recover, that's awesome. And if not, then people can be taken off a respirator with comfort.
And that's the famous page 2 of the MOLST. And a lot of times we look at a MOLST and I open up the page 2 and it's empty.
Yeah.
So, but I explain it to patients as always, never, and somewhere in the middle.
Yeah.
All right, we're going to go to the last break of the morning.
Thank you, Dr. Elizabeth Levine, Hospitalist Director at Northern Dutchess Hospital. And thank you, listeners, for listening to us and being on our show. And you've been with Robin Baker and Dr. Eric Stanberg for a Medical Monday. And it is a Monday, February 14th. It is indeed Valentine's Day, so we'll all be doing something special for our loved ones. This last portion of Kingston Community Radio was brought to you by Herzog's. Stop by Herzog's Home and Paint Center in the Kingston Plaza for all of your home building, maintenance, and painting needs, and discover the difference of buying local. Sales ongoing at herzogs.com. We'll be right back after these messages.
Tom has been a teacher for over 40 years. One day, I think one of the students had asked the question and he didn't remember the answer. And I also noticed that he was letting his class out earlier than they were supposed to let out. I was really starting to worry.
Levi and I talked about how it would change our lives, but he was there beside me.
When something feels different, it could be Alzheimer's. Now is the time to talk. Visit alz.org/ourstories to learn more. A message from the Alzheimer's Association and the Ad Council.
Hey, Dad, your prescription will be ready in just a minute. Hey, Dad, your laundry will be ready in just a minute. Dad, your lunch will be ready in just a minute.
Hey, honey, why don't you take a minute?
When you help care for a loved one, you give them as much time as you can. But it's just as important to take time for yourself. AARP can help. Find free care guides to support you and your loved one at aarp.org/caregiving. That's aarp.org/caregiving. Brought to you by AARP and the Ad Council.
Hi, this is Shirley Stabe from Kingston, and I support Kingston Community Radio, and so should you.
You're with us here at KCR, Kingston Community Radio, AM 920 and 92.5 FM, WGHQ, and streaming online at mykcr.org. Abundant sunshine later today, but only a high of 23 degrees. But we ought to be thankful for that sun. Mainly clear skies tonight with a low of 9. Tuesday, the 15th, 32 degrees high, with a lot of sun, with a few clouds. And Tuesday night, clear to partly cloudy with a low of 14. And Wednesday, 44 degrees is our high, with partly cloudy skies in the morning, giving way to cloudy skies during the afternoon. Then we'll have cloudy skies Wednesday night with a high of 38. This upcoming portion of Kingston Community Radio is brought to you by Ulster Savings Bank. Many locations throughout the Mid-Hudson Valley, one near you. Let's get back to the on-air studio for this last half hour of Medical Monday with Robin Baker, Dr. Eric Stanberg, and our guest, Dr. Elizabeth Levine. Welcome back.
All right, here we are. Welcome to the last half hour of this
Want to talk
show.
about our mothers?
Yeah, we're talking about our mothers in the break. Well, you know what, Robin, it's a little personal, I guess. Robin lost her mother at a young age.
Yeah, she was 48.
And you were in your early 20s.
I was 23.
Oh, my God. That's so young.
She had cancer. But, cancer then and cancer now are very different things. The treatments are, so well progressed, right? We talk about all the screenings and everything. We talk every week about the screenings. And there's this low dose...
LDCT, there was a commercial about it.
Low-dose CAT scan,
this a big topic, big deal.
Onset lung cancer, and that is something like, I would be...
Well, they recently lowered the age for that from 55 to 50. And they also lowered the smoking years from 30-pack years to 20-pack years. So they're really expanding the net. And then they also made the age longer. So, but your mother, unfortunately, was under 50. She still would not have qualified for screening. Right. So I think these screenings probably are going to go lower as time goes on, to 45 maybe. I think colonoscopies recently were lowered to 45, and I think they're going to go even lower, probably to 40. We know someone in the community, a 44-year-old man who recently passed away from colon cancer. So I'm just not, these, I guess there are things in flux, whatever. But again, one of our themes is to encourage people to be up to date on their preventative care.
So are you bringing up my mom because?
Oh, because we were commiserating about our mothers, and something called guilt that they tend to heap upon us. And Robin has really taught me to, because she was not fortunate enough to live with her mother as she became an adult, to really appreciate my parents much more.
Right. I was like, oh, she's calling again?
Yeah.
Lucky you.
Yeah. Yeah. It's.
Take it, Robin.
No, she's the best.
Really? All right. All right. So give us an idea in the time we have left, the life of a hospitalist for a typical day. What is that?
So I usually get in around 8:30 and look at my list and the charts, review them, check labs. We have a bunch of meetings too, like sometimes we have morning report with the residents where we talk about a topic and we teach. And then I run around and try to see everybody.
Run around.
Remember, I'm the slow one. Eric used to come in for his night shift and still see me there at night and be like, "Oh, are you the intern?"
Yeah, are you new? Teasing her for still doing her work.
So, and that's why I didn't make it in primary care, because I was too slow. By the way.
What did they do to us with the too slow?
Yeah, yeah. So hospitalist work is great because I'm on my own time. Right. So if I choose to be slow and work a 12-hour day, that's on me, and it's...
Choose to spend an hour with someone because that's how much time you think they need.
Exactly.
I mean, you have some pressure to discharge people before a certain time, and you really want to have everyone seen, but by the time to take your notes, and finish some stuff up. Yeah.
So I see people. We meet with team, case management team, and therapy and nursing every day to talk about discharges, and which is good. I like hospitalist work because it's a team approach. I really like working with other people. Then I just write my notes, do new admissions, do discharges, then it's 12 hours later, pretty much.
Yeah. So it's what are the advantages of it over the office? I mean, you gave a couple. One was that you have some looseness in making your schedule. It's very tough in the office to stay on schedule, and it's actually one of the most common complaints that patients have about the doctor's office is, why do they have to wait? Then Seinfeld does that whole bit about the waiting room. He says, you're going to wait because that's the name of the room.
I love that. That's great.
And it can be feel like pressure, to keep moving, and then it interferes with maybe end of life discussion that we
Absolutely.
otherwise might want to have.
Yeah.
And doctors like Dr. Levine and many other young physicians have been told that many times that you're too slow, move faster, move faster.
I like that you lumped me with the young physicians.
Yes.
I would like to interject. There's a huge upside to being slower. You're more dedicated, you're more devoted, and you're more thorough.
Yeah. I mean, I wish everyone could have that ability to take their time, and sadly, it's not part of the system, so you don't fit in. I mean,
Volume-based.
You can't survive, basically. Sadly, it's not the right way.
I mean, I think there's an awareness on the part of our public health system that this volume-based business, at least for primary care, is counterproductive. It leads to more, which raises costs, and it leads to maybe things not being better. I'm not so sure how we're going to break ourselves of this habit, though, which is part of the problem.
Yeah.
You know, we talk sometimes about quality, being measured in quality instead of quantity, but that has its own kind of superficial drawbacks as well. You know, how do you measure an end-of-life discussion? You can measure what percentage of them are had, but how do you measure how well it is done?
Yeah.
How beneficial it was to a patient.
Yeah.
The difference it made in their life.
Right. You know, so these are things we have to juggle with. Are there any, what's the word? You know, what do you find the most challenging about doing hospital work? Okay, I'll leave it open-ended. Just
I guess some of the metrics that are used for us, and metrics are like, you know, like Eric was talking about, the Medicare rules, like length of stay or readmissions. Now quality is, patient satisfaction is very important. And the way they measure it in the hospital is when people go home, they'll send a survey to a certain number of people. But we need to be excellent all of the time.
Right.
Like it's like these rules and regulations are frustrating, and those are the things. But in the hospital, I feel like they're there, but they're not as much there as they are in primary care. Like I don't feel like they're over me all the time, and in primary care, I don't think I could do that anymore.
I think it's experienced in different ways. I think they can be counterproductive for a lot of people in primary care because they kind of say, you know, whatever, I'm doing my best. You know, this is enough. You know, you can measure me if you want, but I can't change it. You know.
Yeah.
Or you can kind of go the other route and say, fine, if you're going to measure me in this, that's what I'm going to do. You know, and if everything else, you know, be damned. You know, if somebody's takes more time, sorry, gotta, you know. So that's how the quality movement can potentially is going to wind up with the same results as the volume-based movement. Because you're just changing, you're going from measuring volume to measuring kind of clicks and checks and things like that, you know. So
Patients aren't aware of these metrics. I mean, and a patient's only faced with it after they've had some emergency where they had to go to the emergency room. And if they were sick enough to be admitted, do they know if they're being held for observation or if they stay for 2 midnights or if they don't know. They don't know, you know, what their plan covers, if they're going to be allowed to stay. If they're discharged to rehab, are they aware of the fact that the insurance is only going to pay for 14 days? I mean, it's the only time you ever are faced with that as a patient is when you're in it.
Yeah, right.
And there's you know, I mean, you know, it's kind of like, and I'm trying to think of what to compare it to. Like I hit a deer once. And there was a small dent in the front of my hood, which I was like, oh, I don't want to have a small dent in the front of my hood. So I'll take it to this guy and he'll fix my car. And then I utilized my insurance, which then skyrocketed the cost of my insurance.
Right.
Like if I had known ahead of time, I probably would have fixed it for a couple $100 out of pocket. I wouldn't have utilized, you know, what I didn't know. But it's the same thing when people are in an emergency situation and have to go to the hospital and have no idea, you know, what their insurance policy is, what it's actually going to cover.
Right.
And then they're told that their loved one is, you know, can't stay, that they have to leave because it's not going to be paid for.
Whenever a patient says to me, I have real good insurance, I usually hear that as, you must not have had to use it too much.
That's right.
Yes, if you're kind of healthy, and actually insurances, if you have something kind of well-defined, like a heart attack where you need a stent, they are pretty good. It's when things are a little less well-defined. An illness that's kind of taking a little more time, and, so... But you also touched on observation status, so that's something that might be worth briefly mentioning.
Yeah, but I want to say that, what was it that I wanted to say about it? It just left me. All right, so, I don't really, you probably know more about observation than I do, but it's essentially if you are coming into the hospital for something that will require like one overnight, just because you might need an MRI in the morning, like if you might have had a stroke or a TIA, we call it, a stroke that's kind of come and gone. You might just stay overnight so that you can get an MRI in the morning. So then you're admitted for observation. And it's billed to Medicare more like an outpatient. So, but I know what I was going to say, that at Northern Dutchess, we have case management who sees every patient within 24 hours, and they are the ones who explain insurance issues to the patient. And I have to say that they're a great group, and I feel like we accomplished that. I mean, they haven't explained it to me yet, so I don't understand it, but that's okay.
You must not have used it.
No. So does that explain it?
Observation is, when I admit a patient, is it reasonable to hope that this patient's going to be able to go home tomorrow.
Yeah.
But sometimes some unusual things become, observation, like people who need blood, like transfusions.
Yeah.
That's a little...
Because it's something that if you could set it up as an outpatient, you could probably do it, but you can't.
By the way, it's very hard to set up as an outpatient, at least from a primary care point of
Really?
view. Yeah. It's just, we don't have to go into it now.
Okay, we'll talk about it offline.
But we have our HEMONC colleagues, and I usually hope they will do it.
Oh, they manage that upstairs. Okay.
I could probably try to do it, but it really takes a lot of work, on a lot of time.
So you asked me about what else is good about being a hospitalist. Yeah. The best thing for me is that when I'm off clinical, I'm off. Like I don't. What'd you say? How many?
Oh yeah,
you didn't look at your charts or your email.
I took 2 days off from the computer, which is unusual. And when I logged on, because I had to do something while we were sitting here, I have about I've got to work. I have about 50 sets of labs that need to be reviewed,
and that was during your off time.
Right.
Yeah. So when I'm doing hospitalist work, and I'm off, then maybe you're taking over my shift or Scududo, and I'll look and see just because I'm interested in what's going on with the patient, but I'm not responsible anymore.
You could be like one of your colleagues and send me texts all day after.
Yeah.
We're not going to say who that is.
I do that too sometimes.
I know, I'm joking.
We definitely do that to each other.
That's fine. It's fine. It's fine.
Well, that's that team approach you were talking about.
Yeah. It's patient-focused care.
There's a new term called pajama time.
Yeah.
Which usually refers to maybe a younger physician, maybe a mom, so she goes through the day and probably told she's not moving fast enough. And I shouldn't say she, because it happens to male physicians as well. And they go home, you have kids, you maybe have dinner, you do a little homework, kids go to bed about 8:30 or 9, and you kind of log on the computer for another 2-3 hours.
You don't need to have kids. All of us are doing it.
Right.
Yeah. That's what people don't see, that it's endless.
Right.
The work is really, it's like a bottomless pit.
It kind of is, and I wish I could see the changing. I'm not so sure it's going to change in the amount of time I will have left in my career.
Well, I think we all, like I tell the residents, you have to think about how you want to live your life.
Yeah.
And me that I've always worked a little part-time because I'm the daughter of a workaholic, and I never wanted work to be like 150% of my time. Right. So I always wanted to carve out time that I could do the things that I love. And but I don't think people do that enough, but I think we can. In medicine, you can say, I want to work 80% time, and even though that will mean full-time for you, I just think that it's important to decide how you want to do it and then ask for that, basically. Yeah.
Okay.
Right. You see the differences in even teaching, don't you? Now, I mean, I have the benefit of being with you and knowing you as a teaching physician and just a clinical physician. And
But I get to work with the residents?
correct. And you see that as residents, you're seeing the difference in your own residency as to what these physicians are, how they're training.
Yes and no. I was a resident right around the time that they started to institute the famous Levine rules, which were regulation of the amount of time a resident could work. You might have been right before them, or right during the kind of transitional time.
Around the transition.
Levine was the daughter of a rather prominent journalist in New York City. And she had passed away, unfortunately, from sounds like an overdose, combination of medicines. It wasn't like a drug overdose. It was interactions of medicines.
Psych meds. And
right.
Yeah.
And when it was investigated, it turned out that the resident had been on for like 36 hours straight or something, and really began to kind of shed light that these were...
that you're just people?
Yeah.
And that you can't work for 36 hours
Especially
straight?
at the same time being responsible for people's lives. And, anyway, so that led to regulations limiting hours that residents could be forced to work.
Right.
What are some of your favorite things to do when you are off?
Oh, that's a good question.
Elizabeth.
For me, well, I love hiking, and could spend hours in the Catskills. I've done all the peaks, and I'm doing more, and yeah.
I've been in the valleys.
Love to do that, like Kingston. I'm a yoga teacher, and so I teach now on Zoom with just the group of my people who have been coming to my class for a while. I love to study mindfulness. I like to teach it, and really involved a lot in my own growth, I guess, in a lot of ways. Yeah. So I do that, and I think that inspires me to bring it to places like the hospital to just help people take care of themselves too.
I'm inspired, but not surprised.
And a role model for me.
Oh.
Yes.
That's that self-care that you're talking about.
Yes.
That enables you to take care of others.
Yeah.
Well, you talked about being the child of a workaholic, which is kind of the opposite of self-care. So that, kind of brought you to that.
Yep.
I think I'm the child of a workaholic, and I'm still a workaholic.
But you think about it.
Yeah.
You're in the contemplation stage, right?
Yeah, I gotcha. Yes.
You have your escapes too.
Yeah.
You do. You have the that wonderful group that you're playing with all the time.
Music.
Oh yeah, music.
Right.
Yeah.
And actually, this show
Very
is
healing.
This show is something that's
Kind of
that
an
takes
escape.
you outside of your regular, and
by all
you're a
means.
celebrity.
Wish I could escape a little bit later in the morning, but
well, you're a celebrity in the
Yeah, right.
doctor's office too, but still, it's a beautiful, not a juxtaposition, but but really a synergy.
It's part of, they taught us this in medical school. The root of doctor in Latin was to teach. So in a way, the radio show is, teaching and then trying to educate people who are listening about their health, but also their resources in our community.
And you teaching the residents is also, I know it's part of your job, but I think it made your job less straight.
Yeah, I like working
outpatient.
with residents. I like working with students. I a couple basic reasons. One is you mentioned the loneliness factor. It's someone to kind of share the day with, and I feel that having a young set of eyes in the room, it keeps me on my best behavior. Maybe not so kvetchy, and it's academically good. Because subjects come up, and I think to myself, boy, I probably should maybe dust off some medical school notes and we talk about that.
And of course, they're, like the, medical school programs now are different than
Well, I usually use the
20 years
phrase,
ago.
you should listen to this young doctor because he or she has been educated this century.
Oh my goodness.
I know you're doing your old self
What?
deprecating.
Oh.
But
I'm
the
making
truth
jokes
is
of
that they learn so much from you too. So I mean, you have so much to give and offer, right? I mean, there's really no replacing 25 years of experience and
Right. I do get
all
it-
of that knowledge.
right.
Plus, you have to. I know that the listeners maybe they don't realize, but doctors have to stay up to date. And have to educate that, you can say you went to med school way back when, but the truth is you've been going to school every year. You have to retake your boards. You have to not only are you being educated yearly and required to do those education hours, you are also being tested.
Yeah.
Those
Right.
boards are coming up too.
No,
huh?
thanks for reminding me. I gotta register. No, when I do work with a student and I kind of explain each patient, I sometimes step back and go, wow, I say a lot. This person's been my patient for 15, 20 years.
I know, those relationships
Yeah,
are...
yeah, it's a long time.
Those are amazing. I mean, I know you, and I know your heart is in it for the patients, and that's a beautiful thing. And I miss that about primary care. I have to say, I don't want to just diss primary care from my perspective. I still see some of my patients in the community. Right. Sadly, sometimes they come to the hospital, and I've lost a couple and seen their families. It's those relationships. There's nothing like it.
Well, I worry about the primary care community in Kingston here. I think there's a set of more doctors that probably be retiring in the next few years, and we have to make sure that they're still going to have people to go. The patient's still going to have primary care providers to still go see.
Yeah, I would hope that. It's strange to me that we can't recruit doctors up here that easily.
We have those two young doctors in Highland. We
Right.
Just had, you're going to have to say the name.
Well, one is Hotch and Don.
Right.
He was a guest of ours a couple when we did it from home because we were quarantined.
Yeah.
But he was a guest. He is an internist starting at Highland. And the other name is unfortunately escaping me, but our Highland office does have two. But somebody retired from that office as well.
Right, so they're right picking up the patients that way. Yeah.
Yeah.
Yeah, we have some residents coming locally. So that's
we
cool.
do, and I can't wait to have some residents on the show. What do you think? Some of them like to talk.
Oh, that would be great.
Yeah.
Yeah.
Maybe we'll start getting them on the show. They get up this early? They do. They got to go to 6:30 rounds.
Well, you found that from your residency here that you call it your litter, that they stayed here, right? They came here to do residency, and then they...
Well, the ones I referred to my litter, and we were all kind of youngish doctors, but unfortunately I'm the only one who actually went through the residency. So, for example, Dr. Scaduto, Dr. Harizny, and myself were all young attendings with the Institute for Family Health around the same time, but I was the only one who actually was a graduate of the program. But that's when I use the term litter, I'm usually referring to Harizny and Scaduto. don't guess which one was the runt of the litter. We won't discuss that. But that's what I mean.
There weren't other primary care doctors?
Yeah,
in the
Dr.
area?
Engel.
Oh, Dr. Engel's, yeah, the other local doctors that around my time afterwards stayed. Sure, I guess
Joe Thierry, but he was just a year.
Dr. Over at I'm not sure what it's called now, but Dr. Dietrich and Dr. Bogdan and Roxana Yorgu are graduates of the Kingston program.
I didn't know that. I know about Aaron because he was your year.
I think it might have been a year after me, but the same litter.
Yes, yeah. Well, the hope for the Institute was to train doctors to stay in the area.
Right, and actually it worked for a long time. If you look at the roster of primary care physicians in the late 90s, almost everyone was a grad. I shouldn't say that, but a lot of them. But since then, I'm not so sure the pattern's been repeating itself, and that troubles me. And we're also looking at what exactly is a full panel, that whole idea. But that's a different topic. We are nearing the end of this morning's show, Robin.
And it was so wonderful to have you,
Well,
Dr.
it was
Levine.
fun to schmooze with you
Schmoozing.
both. I don't get to see you enough, so
we do have a guest next week. His name is Dr. David Templeton. He is the director of the emergency medicine department over at Northern Dutchess Hospital. He'll probably be calling in. I'll reach out to him. But he's an interesting character in his own right. And I'm sure we will talk a lot about emergency medicine and things that affect the ER. But I do want to thank Dr. Levine, and I also want to thank the wonderful work you do and all of the people that work over at Northern Dutchess. I'm very proud to be call you colleagues.
You're welcome. Thanks for having me.
You deserve it. You deserve every bit of those 5 stars, even though you were saying it was just small hospitals.
No, I didn't mean to belittle it. I want to just say that for the record.
You're awesome.
Yes, it's.
I want to wish everyone a happy Valentine's Day.
Happy Valentine's.
You want to wish someone a happy Valentine's Day?
I want to wish Chris, my Valentine, a happy Valentine's Day.
And I want to wish Robin a happy Valentine's Day.
You too, hon.
Okay. Thank you, Dan. We'll see you tonight. We're going to La Canard for dinner. It was either that or Red Lobster. We chose La Canard. Maxwell family. We'll see you back next week.
Absolutely. Okay. And thank you, folks. Thank you, folks. That was a very loving tribute to all the dedication that Robin and Eric and Elizabeth give to the community. It's Monday, February 14th, 12 degrees right now here in Uptown Kingston, kind of like sneaking up to 13 degrees. And this last portion of Kingston Community Radio was brought to you by Ulster Savings Bank. Many locations throughout the Mid-Hudson Valley, one right near you. Thank you for sharing the morning with us and participating in Kingston Community Radio, KCR AM 920 and 92.5 FM, and our live streaming on mykcr.org. Talk radio at its best. Inspired discussions of, by, and for the community. And we invite you to be with us tomorrow morning at 7 o'clock a.m. for our terrific Tuesday. And it will be a terrific Tuesday. And we invite you to keep up with us every weekday. Until tomorrow, we wish you every success in growing and developing Kingston and all our neighboring communities. This last portion of Kingston Community Radio was brought to you by Ulster Savings Bank. Many locations throughout the Mid-Hudson Valley, one near you. We now return you to Magic 92.5.